Hi, welcome to QD Clinic. My name is Eric Dein. I'm a rheumatologist in Summit, New Jersey. And today I'm going to talk about a case called polar opposite approaches to lupus. This patient was a 37-year-old female who was having fatigue and joint pain and was referred to see rheumatology. Her rheumatologist or her primary care doctor had ordered some tests, found that she had a positive ANA and other subserologies. But when I was looking at her chart a couple days before the visit, I find, wait a minute, she's in the ICU. 37 years old, no other past medical history, never really seen a doctor before. Apparently, she was found down and unresponsive just a few days before the appointment. She had a cough leading up to this, and when her family arrived, they found her unresponsive on the ground, and EMS found that she was in hypoxic respiratory failure. She arrived to the hospital, was diagnosed with multifocal pneumonia, given Solumedrol in the hospital, recovered very rapidly, discharged on prednisone 40 milligrams. So what's going on here? She isn't on any kind of immunosuppressive medicine. Why is this seemingly previously healthy patient coming in for some abnormal serologies all of a sudden in the ICU? And how do we approach this? So I come in to see her a couple days after she left the hospital. She actually did have quite a bit of serologies that are notable. A positive ANA, it was direct, the one that was sent prior to me. She had an SSA, SSB, Smith, RNP, double-stranded DNA. She had high inflammatory markers. On her exam, she had lipidoreticularis. She had Raynaud's. She had a pretty extensive erythematous rash on her hands with what looked like cutaneous vasculitis of her fingers, and she had a rash on her trunk. And so certainly a very active lupus picture clinically. Um, uh, what's going on with the lungs? Is it infectious? Certainly the most important. She was continuing to have dyspnea, continued to have lung findings on her imaging. So we very quickly got her to get a bronchoscopy to rule out any infection. And very importantly, in lupus patients, thinking about diffuse alveolar hemorrhage, fortunately negative for both of them. So this appeared to be acute lupus pneumonitis. It's relatively uncommon. It's listed between 1 to 12%. It presents often with this rapid onset of fever, cough, dyspnea. In about half of patients, it's their first manifestation of SLE. So she responded very well acutely for prednisone. So what's the approach that you would take with this patient? Well, the other thing I did not mention initially is that when she comes in to see me, she's also wearing magnets that are stick to her body. So she's got this magnet approach that she feels is the reason why she has responded very quickly. Um, Certainly, this is outside of conventional medicine. My approach is you could continue to do these therapies as long as they're not going to do anything that interferes, but let's also really focus on goal-directed therapy. So we worked on prednisone. Prednisone certainly key in the short term for her. We know that 80% of organ damage in 15 years is attributable to prednisone. So very important to get her on other therapy. My plan ideally would be to start both hydroxychloroquine and probably a very early intervention of a biologic type medicine like belimumab. But for her, my plan is to go slowly come down on the prednisone. I think of it like tortoise in the hare, not to rush it and end up back where we are in someone who compliance is a concern. Starting with the hydroxychloroquine, trying to get buy-in for her, and discussing it with her family members who are more inclined for the medical intervention. Being honest up front, telling that it is a lifelong diagnosis. She will need long-term treatment, and likely will need multiple, but taking it slowly. So building rapport, not accomplishing everything all in the first visit, seeing this patient often, and checking in with her often to continue the conversation. So the interesting things about this patient, who I'm still very much getting to know right now, is this acute, pretty dramatic presentation of lupus pneumonitis, and then also not always taking the initial approach that you would want, but taking things time by time, having this relationship building with the patient. and getting their buy-in to find the treatment that works for both the patient and the physician to control their disease. Tune into Room now for lots more coverage for QD Clinic and more for Lupus Month with the Room Now faculty.